Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Vendor Education Series, and I'd like to welcome you to our latest session presented by BeneLynk. Our presenters today are Vicki Jessup, Vice President of Government Relations with BeneLynk, Heidi Eccleston, Senior Director of Program Development with Banner University Health Plans, and Kesley Crichton, Chief Sales Officer with BeneLynk. And they will be presenting minimizing Medicaid disenrollment through integrated outreach strategies. But before I turn it over, I do have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines, and these guidelines can be viewed on our website. We will be recording today's call, and we will post the slide deck and recording on our website by tomorrow morning. The link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a vendor, be sure to check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. You can also post a note or even RFP on the Preferred Vendor Connection portal. And of course, during the session, you can ask a question at any time by clicking the Q&A icon in your Zoom window and typing in your question. And all questions will be answered at the end of the presentation. Now I'll pass it over to Kesley to get things started.
Thanks, Ron. Hi, everybody. Thank you for taking some time this morning or this afternoon, depending on where you are, to chat with us. I'm going to do a brief introduction of everybody and go through the agenda, and then we'll get started. So I am joined today by, as Ron said, Heidi and Vicki. Heidi is our newest customer, and we're so thrilled to be working with her. She's from Banner University Health Plan and an ACAP member. And Heidi is the Senior Director of Program Development and brings just tons and tons, 20 years of experience working in various healthcare settings in Arizona, Utah, and in Florida. She has extensive knowledge of both operations, but also behavioral health systems. And she's written numerous proposals and requests for proposals through the ACAP Access, Arizona Access Procurement System, and has also kind of started some plans where SMIs are really the focus of some of her knowledge. So we are thrilled to have her. She's also a native of Wisconsin, which brings me to my next speaker. Vicki Jessup is also from Wisconsin, and Vicki has been with us for several years, but her history goes back to Medicaid eligibility. She's just a subject matter expert on every pathway to Medicaid that you can imagine. And she works across all of the different business units at BeneLynk to make sure that we know those different pathways to Medicaid, know how to make sure that we keep them, all the various attributes of each state, as well as CMS for Medicare Advantage as well. So I'm going to turn it over to Vicki to kind of kick us off first and kind of talk about what the situation is, both in Arizona as well as nationally, and what's going on with these numbers. So obviously, we did not really have an extension of the PHE again. So what that means to us, this number keeps growing. We think that the amount of members that can lose Medicaid is probably at least half of this 14 or 15 million is going to be due to administrative barriers. And so while it's been great to have the PHE in place from a membership and a retention standpoint, right, the unknown of what this means to our health plans, our states, and our members is really where the kind of the push for information coming from the federal government is desired, right? If we had a date and if we could respond to it, I think everybody would be a lot more comfortable. So Vicki, can you kind of take us through where we are right now?
Sure. Good afternoon, everyone. I'm sure everyone's already heard the news. States did not receive the 60-day notice that they were promised by the Biden-Harris administration in November. I think it came as a huge shock to all states based on what I'm hearing. Everyone really thought January was going to be it. But without that notice, now we know it will likely extend until April. We know with certainty it's not going to expire in January. So if it is another 90-day extension, that would be the 12th extension. CMS or the National Association for Medicaid Directors, right before the holidays, did send out a letter to Congress asking for a few things. They asked for a 120-day notice instead of a 60-day notice. They asked for CMS not to change any of this guidance, which was provided in March of 2022. They also asked for certainty that states wouldn't be required to implement changes that have been proposed to align MAGI and non-MAGI eligibility during the unwinding period. But back to this slide in particular, in March of 2022, CMS did issue guidance to states, and they gave them 3 options for starting their unwinding period. So option A, states can start it basically as soon as they get notice. With option B, they can start at the month that the PHE ends. And then with option C, they would be starting the month after the PHE ends. So if we go to the next slide, Kesley, what that translates to, if the PHE ends in April, the states that elect option A would have disenrollments beginning May 1st, so eligibility would extend through April 30th, the month of the PHE ending, but no coverage as of May 1. And then states that are in option B would have termination starting 6/1, and then the states choosing option C would have disenrollment starting 7/1. So one of the things I've been doing at BeneLynk is trying to track which states have picked which options. We do have at least tentative plans, A, B, or C for most states, but last I checked, there was still about 10 where we don't know yet, and the states didn't know either. They said they still haven't decided. So this is just a depiction of the CMS guidance and how it translates if the PHE ends 4/11. Who knows? Oh, Cass, I think you're on mute.
Thank you. Could see
Yep.
my mouth move, but not hear anything, huh?
Mhm.
Thanks. So I think we have several states that have been a little bit more proactive with doing their Medicaid renewals, and some of our clients have been proactive too. And it's a good way to kind of be efficient and check in with your members, even if it was just to update contact information. And so some of this is what we've been doing with Banner University. So I'm going to ask Heidi to take over and tell us a little bit about her health plan.
Excellent. Thank you, Kesley. So Banner University Health Plan is a nonprofit health plan, and we're dedicated to serving the people of Arizona. We are actually a division of the larger Banner Health delivery system. So Banner Health has 30 hospitals and specialized facilities across 6 states, and we're headquartered here in Phoenix, Arizona. For over 20 years, we've provided the best-in-class healthcare to our members to ensure that they have healthy outcomes. So currently today, we currently have about 312,000 Arizona Medicaid members on our health plan. And that's with both our Access Complete Care health plan and our Arizona long-term care line of business. So with our Access Complete Care, we have about 306,000 members, and on our long-term care, we have about 7,000 members. Next slide. So what are some of the challenges that we're working through both internally and alongside BeneLynk as we look at how we get all these members through this renewal process? So as many of you know, Medicaid has historically had retention issues, right? These were issues before the PHE, and they will continue to be issues after the PHE. What we do know is we do not want members, what we want to accomplish is to have a decrease in the number of members who churn through the system. Members who fall off and come back on and fall off and come back on, that just is unnecessary cost to both the states and to our managed care organization. So really that is one of our main goals, is to really ensure that we outreach these members and we get them through the process. So what are some of the challenges we're seeing as we started this member outreach through the renewal process? Is one, across any state that I've worked in, is the inaccurate phone numbers and addresses that we get through the enrollment file from the state. And this is for a number of reasons. As we know, members may change phones frequently when they run out of minutes, or they found a plan that's a little bit cheaper. And a lot, especially during the PHE, when there was the economic crisis, we saw members who needed to move frequently just due to, income or loss of income. So it's been a challenge just ensuring that we have that correct information to outreach to our members. Another area we're seeing is just a lack of knowledge a lack of knowledge about the renewal process. And that's especially true with members who are new to Medicaid, right? They never were on Medicaid prior to the PHE. And so they're not really familiar with what the renewal process all encompasses. What do they have to provide if it can't be done automatically? So really getting the education out to our members is key. Again, we have a large homeless population in our Medicaid plan. And so really what we've done is we've partnered with some of the larger shelter campuses here in Arizona to work proactively with them to get the information out to members that are on the streets or in some of the encampments, as well as working with some of our provider partners who provide that boots on the ground kind of approach to help us engage members who potentially could be homeless. And then like everybody else, we have a literacy and or language barrier. So just ensuring that we are providing the information in languages or the literacy level that the member can understand. Here in Arizona, like other places, we have a very high, we have large pockets of rural areas, especially when we're looking at our tribal communities who may not have any internet bandwidth. So really giving them just the option to go through the state portal to do their renewal is not an option. They just don't have the bandwidth to do that, as well as phone, the phone lines that you can call in to do your renewals. There's long wait times right now. And so those members, are getting, frustrated, it's eating up their minutes. So really thinking about other options to get members through this process right now. Next slide. So we're going to touch a little bit on our vendor selection process and how we got to partner with BeneLynk and why we partnered with them. So we vetted out 5 vendors through a very, a specific process. And really there was a couple of things we really were looking for in a vendor. One was a vendor that knew the Arizona landscape, a vendor that knew access the Medicaid agency here in Arizona, and then a vendor who was really innovative, thinking outside the box on how we go about outreaching these members, how do we find them, how do we get good phone numbers. And so that's how we came about to partner with BeneLynk. And on the right side of your slide, there's really 4 major things that we really stood out for us when we were vetting out the vendors. One was BeneLynk's multimodality outreach approach. So we're looking at text, we're looking at mail, we're looking at warm agents, just a variety of ways to outreach members. Another key component was they are a registered access community assister. So when we were talking with some other vendors and they were doing the warm agent outreaches, one of the steps that they were not, who were not community assisters, is that if they had a member on the phone, they were providing the various options to renew. So go to the portal, go to the 1-800 number, go down to DES and so forth. And we just thought that's a key opportunity right there when you have that member on the phone to really engage them and help them walk through that process. And I'll go into a little bit more on the next slide about what that looks like as a community assister. But as we know, when hanging up with a member who we've just finally engaged on the phone and asking them to take another step when there's a lot going on in their lives, it's just not the best way to really help members get through this process. And then 2 other really key aspects that BeneLynk brought to the table was their pricing model. It's really based on performance versus number of member outreaches. So instead of paying for every time a communication goes out to a member, we're actually paying every time BeneLynk is successful to get a member through the renewal process and they remain on our health plan. And then just the robust monitoring and tracking that's unique, that's just for Banner. So we have our, it's in real time. I can go out to the, the dashboards and see where we're sitting, how many members have been touched, and report back to my executive team. Next slide. So this side just goes into a little bit more for those who don't know what a registered community assister is. So BeneLynk is contracted with Access as a community assister. And so what that offers is that BeneLynk warm agents can help members apply and renew online. So they can assist members through the redetermination process. They can submit documents on behalf of the member. They can electronically sign the renewal application on behalf of the member. And it also allows them to track that application, right? As it moves through the process, if it gets hung up for something that was missed, they can see that and be proactive and intercede and make sure that whatever piece of information is missing or what wasn't clicked or something gets done and the application continues to move through the process. Another thing is if there is a problem that arises when you're on the portal and you're helping a member through the process, they have access to a special call center that can help resolve these barriers right away. So you're not sitting in a queue where the community is also in that queue. It's just for the community assisters. So that is a really key partnership right there. Next slide. So how do we partner with Access, our state Medicaid agency, and other MCOs here in Arizona? So Arizona has about 630,000 members that will be affected once the PHE ends. So we have about 630,000 members across the state that need to take some sort of action to see if they still qualify for Medicaid benefits. In a recent number I just read the other day, there's about 15 million people across the United States that will be affected. And there's two subsets of populations that we're seeing in our files that we're getting from the state that are more impacted than others, and that's children and young adults. And so we get two files from the state. One file is the verification failure file, and that file are members who need to take some sort of action. So maybe they need to update their address. Maybe they need to provide income verification documents to get them through the automatic process. The other file we get is the factual eligibility failure file. And that file are members who at some point during the PHE went through the renewal process, but were found to no longer be eligible for Medicaid. So that could be for various reasons. And so what we are targeting with that group of members is we're really ensuring that they understand as we get closer to the end of the PHE is that they go and they complete another renewal to see if anything has changed and they may qualify for Medicaid benefits still. And so some of the information we get on the file from the state is member demographic information, the date the COVID override started for this member, the next renewal date, and then the failure reason descriptions. And so some of the failure reasons examples are, need to verify income. There was no signature on the application, or maybe they failed to answer a certain benefit question. And so this is really key information that we provide to BeneLynk. So as they are outreaching our members, and get a member on the phone, they have some additional information as to what failed for this member when they were doing a renewal, so that they can provide that information to the member to be more personal. Next slide. So what are some of our goals as we worked with BeneLynk and the health plan and what we want to see? So number one, obviously we want to see members retain their Medicaid coverage. That is key. We don't want to see disenrollments. We don't want to see a cost of the system that doesn't need to be there. And through this relationship with BeneLynk, who's really providing that concierge service for Banner University Health Plan, we really hope to see improved member experience, right? Really giving our members that warm touch to help them get through the system where they'll want to stay on Banner University Health Plan as their Medicaid coverage MCO versus other MCOs in the state of Arizona. Again, as I talked about, we don't want to see disenrollment. We don't want to see unnecessary costs. We do partner with our marketplace product. So Banner University Health Plan does have a marketplace product, and really we're partnering and collaborating with them. So when we do identify members who may no longer be qualified for Medicaid, could they qualify for one of our marketplace products, which is key, right? If they don't qualify for Medicaid, other affordable options out there for them. There are some studies out there that say about a third of the adults that will lose coverage once the PHE ends could be eligible for a marketplace premium tax credit product. So we want to really educate members on other available options out there. And about 57% of children that are potentially could lose coverage could be eligible under a CHIP program. So for us, it's really educating members if they are not eligible again for Medicaid, what are some other benefit options for them that are affordable for them so that they can maintain health coverage.
Great. I think we're coming up on 4 or 5 weeks of outreach?
Oh, yeah, sorry, I do have
Yeah.
another slide.
Yep, you got one
Yep.
more, the last one.
So too funny. So yeah, so BeneLynk started outreach for our population on October 20th. And so to date, as of November 30th, these are some of the numbers that we're seeing. So we're seeing about 68,000 texts have been sent to our members, 45,000 pieces of mail have been sent. And in conjunction, at the same time, we as a health plan are also mailing our members educational materials as well. So that's just what BeneLynk has been doing for us. And then about 20,000 follow-up calls. So those are calls that maybe are coming in from the text and mail into our dedicated 1-800 number with BeneLynk. Those are live agents outbound calls. Education provided about a little over 2,000. So that's folks who maybe have some questions, don't understand, just need a little bit more guidance. And then we've gotten, BeneLynk has been able to get 222 members through the renewal process. So that's great news as we hope to continue, and we'll see that number rise. And what I was really astounded by in looking at this data is only 386 members have opted out of the text. So when really you do the math, that's only about 0.6% of the members who have opted out of text messaging. So that's obviously clear to us that text is a way to communicate and an effective way to communicate with our membership.
Yeah, thanks, Heidi. I was happy with that number too when I put that on the slide the other day. That was great. Just to go back, the application IDs captured, that is specific to the community partner. So when we go to measure success, what Heidi's going to be actually paying for is those members that we've provided that education, that a human has spoken to another Medicaid beneficiary, right? And that they've stayed on the plan past their renewal date. The application IDs captured are those that said, yes, let's take care of it right now. You can log on to the community partner website and do it for me. So we're hoping that all 2,200, as well as everybody else that we've spoken to, actually completes their renewal. But the 222 is the ones that we've actually completed it for them. So I'm going to shift gears a little bit, talk a little bit about BeneLynk, not just about Banner University Health Plan and how we kind of structure this across the board. First, I'd like to say that our approach is always flexible and that we are working with multiple different clients that always have maybe a little bit different approach that they want to put into place, and we're open to that. We do think for managed Medicaid that texting first is a great form. We know that 97% of these members have a cell phone and most have smartphones. So that text messaging is something that's always at hand, but we do like to follow up with all modes of communication, including mail and live advocates. Everything we do, regardless of what channel it is looking to drive a communication back with one of our advocates. So the text message has the phone number embedded in it. The email has a toll-free number or the piece of mail that they receive. So everything has an easy way for that member to pick up the phone and ask questions or ask for help. When we do a new client implementation, we are looking at pretty easy. We need data from the client, whatever files they're receiving from the state, as well as they need to approve our materials, which for managed Medicaid means that you have to submit it to state approval. So we gave Heidi, copies of the mailings, copies of the call scripts, the talking points, and the text messaging. That all got submitted besides their own marketing people, but to Arizona for approval as well. So we just, we know that every state's different here, but we do this across D-SNP plans, Medicare Advantage, MMPs, as well as managed Medicaid. We think it's also a good opportunity to drive brand awareness and loyalty by including our Community Link service. And our Community Link service is our SDOH program. It's especially if you have any type of P4P tied to this in your Medicaid plan, it's a great way to gather additional information about challenges that your members have been having, to get some health equity type of data elements collected as well, but also to surface a solution. And sometimes the solution isn't for that particular member, but maybe somebody else in their household that you need to help. But it's some way to really kind of differentiate yourself and go that little extra mile without taking up too much time or adding a lot of cost to the renewal process. So we also want to, this is something that Vicki works really hard on, right? Making sure that we're dynamic, that we know the information available in every state. So when we're talking to the member, we know how many days they have until their renewal. We're getting that off the file. We know what type of Medicaid they have, what state they're in, and what that Medicaid plan is called, right? So, Arizona Access versus, Wisconsin's Badger Care and so forth. And so that we're always using the same language that they're receiving in communications from their plan or from the state. And then we're able to guide that member through every different option that that state provides. Is it, you have a mobile phone? Can you download an app that that state might have? Can you do it online? Can we do it for you because we're a community partner in that state? Do you have to make a phone call or do you have to mail something back in? But being able to answer all those questions and have state specific information is really crucial to, I think, making sure that we have validity and credibility with those members. And as Heidi said, we want to use all forms of communication. Not everybody responds to the same one, but we start by prioritizing members. We could do it based on renewal date, of course, but also what different priority files might the state be having. So with Banner Health, we had a list of about 40,000 members that had failed their verification and failed their recertification in some shape or form that we could prioritize. Their recert dates were in the past. And then we started outreaching to the rest of those members starting about 90 days out. And the reason we start so early is we want the opportunity to update contact information, to find new phone numbers, new addresses, and to get that member to update it with the state specifically so that they receive the appropriate renewal paperwork in the mail. And again, our goal is to have a human-to-human conversation, to get somebody on the phone, to answer their questions, to do the work for them if it's available in that state, and to incorporate anything else that health plan client wants us to do, whether it be around SDOH, whether you want us to find members that also might qualify for SSI disability, or whether you want us to give them a flu shot reminder. It's really easy. Once you get them on the phone, right? You don't want to lose them. That's the hardest part. So wrap your arms around the member and let's find and be as efficient as we can, not only for our clients, but for your members as well. And this just kind of illustrates what I was saying before. We cast a halo effect on our outreach. So we're going to outreach to everybody that we can reach in any of those modes of communication. Everybody will receive a text, an email, a piece of mail, or a phone call, right? But only those members that we speak to, that we've educated, so they've validated who they are, they've chatted with us, we've completed an educational interview, we believe they still qualify for it. Those are the members that, as long as they're still on after their renewal date passes, that we actually bill for. So, and we think that this, depending on population, a DSNP, this goes up to more like 40%, right? But for a managed Medicaid plan, 15, 20%, if we're reaching them and speaking to them, those are pretty good contact numbers. And we hope that based on prior experience with other clients, that 70% of that 20% actually completes their renewal and follows through with us. So we have one polling question we'd like to ask everybody. Ron, can you help me out here? There you go. Is your organization already texting your members for any reason related to benefits or health? So just looking to see what these numbers are. I'm not sure how long I need to wait for this. Pretty yes or no question. Thanks. Okay, so a lot of you, this is great news. So yeah, and I'm not sure how many people on the phone are from a managed Medicaid plan versus Medicare Advantage, but I think this is wonderful. And we've seen this to be just a really, really effective way to increase our engagement in both our Medicare Advantage clients as well as Medicaid. And there's been a lot of talk about, texting, right? CMS has written a letter to and HHS requesting that the MCOs be kind of excluded from the TCPA regulations that prohibit that. And I think it's just really important that, if you ask Manat or some of the big legal experts, right, delivering healthcare should be excluded from TCPA. We're not calling these people on behalf of trying to sell them something new. We're calling to educate them about benefits that they're entitled to and helping them keep it. And so with Arizona Access, they were all for this. They approved this easily. They already had some sample text messaging that they had pushed out that we were able to integrate into our outreach. And so that process was really easy to do here. But I'm glad to see so many people are doing this as well. So this just also shows you what our text messaging looks like. The first one is about updating contact information, and we're really giving them the information that they need to go right to the Arizona Access website. They can click on it. It will open up right to that page and they can update their contact information. We're encouraging them to complete their renewal. They're given a toll-free number, and that toll-free number rings in our shop. We are open 8 to 8, regardless of time zone, including on Saturdays. But if they get that, if they call in the middle of the night or whatever, they get a voice recording and we call them back the following day. And they can always text help and we'll call them back from that also. And then there's an opt-out stop that you saw earlier. I think it was 386. So we're thrilled with the results of this text messaging program so far. And then our mailings are also dynamic, right? Everything's consistent with state agencies. They're approving it. We give them all the information they need if they want to complete it on their own, be a fax, mail, or whatever that state happens to offer, as well as a toll-free number and our hours that they can always call. It's a specific call for action. It's normally written in 4th grade literacy level, and so it's really easy to read and really easy to follow. So the other thing that I wanted to talk about just briefly is what else you can incorporate, because again, the hardest part about this is actually getting a hold of these members, right? So when we do that, we think using renewals and their renewal date as a starting point is a really good way to integrate other opportunities. Our Community Link program, as I mentioned before, is our SDOH solution. It's our opportunity to have a conversation with a member, to ask them a few short questions about what barriers they might be experiencing, right? And our clients can determine what those questions are, but normally focus around housing, transportation, food insecurity, financial insecurity, and so forth. And included in our standard program can be those short little questions. We like to keep it at about 3 or 4 because we're talking about so many things during this call. We can also do what we call Community Link Plus, which is more of an SDOH full assessment. We're licensed with Prepare, which is who NCQA and CMS is recommending for the standardization of that questionnaire. And while we're speaking to them and we're screening them for different barriers, we can also start the application for SNAP if they're not already enrolled, or also include some questions to determine if they've already applied or tried to apply for SS disability and be turned down, or ask them some questions that might determine whether they could be potentially eligible for that benefit. All of these are just really good benefits that put money in the member's pocket, sometimes increase the revenue to the health plan as well, getting members to be accurately categorized for SSI when you're owning that risk is a great way to make sure that you're getting paid accurately. And this just kind of walks through, I think the biggest difference to our SDOH solution, Community Link, is when we integrate it, it allows us to lead with help. It allows us to start a conversation that's much more personalized before you start asking the member to do something, right? So asking them about what their challenges are, documenting those experiences in a systematic way. We're going to give those barriers back to our clients using ICD-10 Z codes, but surfacing a solution right there on the spot, right? There's nothing more frustrating than saying, oh, I got this problem, and somebody saying, well, I'll call you back next week to help you solve it. So having that conversation, surfacing solution, getting that member enrolled in other programs that they might be entitled to, as well as documenting other health equity attributes that you might want to be collecting, whether that be race, ethnicity, veteran status, and so on. I think it's just a really good way to have conversations with your members. The Prepare application goes across the standard domains that we've been discussing, and we can include the full one or the short one. And then SSI disability is, I think most Medicaid plans are probably doing this in some shape or form or another. It's a tremendous benefit for both you to make sure you're categorizing that member accurately and increasing your revenue, as well as putting some additional needed revenue in your members' pockets, right? But it's a hard application to get approved, and the backlog from the supplemental security income program through SSA is long, right? A lot of people, there's no really good vendor out there that wants to do this because there's not a lot of revenue to helping a member with a new application. So having this sponsored by your health plan as a way to make sure that everybody's, correctly documented, I think is just a nice way to do this. A lot of vendors do this by looking at claims, which gets some of that information, right? You're going to find some people that qualify that way, but also just asking these questions while you're speaking to the member already is another way that we really prefer, is to having that conversation, not just mining claims for the low-hanging fruit. And that's really it. So when we put all of this package together, right, our goal is to make a positive impression on your members, as well as, because of that, to improve member experience, to improve your tenure and your retention, to make sure, particularly in this scenario, that we are driving increased retention due to lowering disenrollment due to administrative barriers. So making sure that everybody knows how to complete their renewal is what our goal is here. Accurate revenue, keeping those members on your plan, right, helps improve your revenue flow because you're reducing that churn, as well as finding other avenues with SDOH programs. We know that that makes up such a large component of the cost of our healthcare. If we can minimize those barriers, as well as helping make sure people are enrolled in SSI, if applicable, make sure that you're getting complete and accurate revenue. And of course, we just want everybody to be a happier, healthier member at the end of this, and refer their members back to Banner University plan as well. Refer their friends back to Banner University. So do we have some time for questions, I think? And did any come in on the Q&A?
Yes. Hi, everybody. Sean Libby, I'm the president of BeneLynk, and I have been monitoring the Q&A, so I'll jump in with the first two that I saw.
Thanks,
So the
Don.
first one was, will you fully complete the renewals in states other than Arizona? Which is a great question. So we're really fortunate in the state of Arizona that we're able to be a community assister, and that allows us to be registered with the state and allows us to actually be able to physically complete the renewals on the member's behalf directly with the state. We definitely do that in other states anywhere it's available, but there certainly are states where that's not available. And there we're doing what we're always going to try to get the member as far along in the process as we can within the constraints of a given state. So in a lot of states, that means we're going to get in touch with them. We're going to give them the information on the different options that are available to them. We're going to make a plan with them and make sure they have the information they need. And then if they want to go through it while we're on the phone, that's great. Or we're going to make sure that they have a plan and they know how to contact us if they run into any questions. But anywhere there is such a community assister program, we do register for those. So wherever possible, we want to do that. Let's see here. Do you have experience working with Wisconsin plans? I'm with CCHP based in Milwaukee. So yeah, do we have experience working with Wisconsin plans? Cass, I'll let you take that one while I read the next one.
Sure, we do. We work with several Medicare Advantage plans right now, and DSNP plans. I do not have a managed Medicaid client currently in Wisconsin. We have a couple nationals, but we're not doing any outreach. But we have Vicki Jessup, who used to run the state eligibility Medicaid program there. So Vicki, I don't know if you want to chime in if there's a specific follow-up question to working in Wisconsin, but she would be our best person to answer it. So if you want to type something else in there.
Yeah.
Sure.
Okay, so one other one I see here. Are you allowed to send texts outside of Arizona? It's another great question.
Yeah.
We're really fortunate. Access, we think, is a very forward-thinking state Medicaid administration, and they've said, yes, this is important. You can do this. Certainly, I think it's a gray area nationally relative to text at this point, and that's why CMS has requested that guidance from the FCC. I'm really surprised it's taken this long for one government agency to respond to another, but maybe that's my naivete. So the answer is that we're really going to want to talk about the unique circumstances. It's great if the state Medicaid administration will sort of step up and say, yes, you are allowed to do this. And there's ways that you can sort of pose that question to the relative state Medicaid agency. If we can't get comfortable with it, if we can't get your attorneys comfortable with it in a given instance, then we can do things like try to get folks to opt in through other means so that they've affirmatively opted in to text messaging before we start our campaign. But as Kesley said, we're really, really flexible. And that's an instance where we're going to be pretty consultative about our approach.
Yeah, we have customers all over the board from one extreme to another. Some say absolutely not. Some are including the question on the back of their enrollment forms. Some are very proactive about sending a lot of information out regarding benefits or, reminders and so forth. So it really goes from one extreme to the other. And as Sean just said, we can do double opt-ins, right? We can ask them one time and we can text them to make sure. So there's all different ways to kind of make you feel more comfortable that the member has actually requested and that you have an audit trail that they've requested and authorized you to text them.
Okay, and I did see a follow-up on the question about Wisconsin, and basically asking if we are able to complete the renewals through a community partner connection there in Wisconsin. Vicki, maybe if you want to jump in on that one.
So Wisconsin is different with their access program than Arizona. In Arizona, as a community partner, our staff are able to log in as BeneLynk staff, right? Sean Libby can go in and say, I'm logging in, Sean Libby's my username, LaShawn's personal password, and he can do Kesley's renewal. In Wisconsin, they don't have that same partner functionality. So we would be required to set up a member account. Their username, their password, their secret questions and answers. And at least at this point, we have opted not to use complete renewals in states that require those member accounts. But it is something we're still talking about and considering. But at this point, we're community partners in states where our staff can log in as our staff and we don't have to create member accounts.
Yeah, we've taken the approach that we really don't want to be sort of creating an account for the member where there's like dual factor authentication. And then we're getting into a stage there where we would have to be acting as if we are the member. And that's just not really where we want to go. So currently in states like that, as I said, we're going to give them the information. And then if they want to go through the steps while we're on the phone, that's great. And then if they have any questions, they can contact us. And as we said earlier, we're only paid if that person successfully navigates the process.
One other thing about Wisconsin, and actually all states, and Kesley touched on this, is we do have all of those tools at our advocates' fingertips. So when they are talking to a member in Wisconsin, they can say, hey, you can go online to www.access.wisconsin.gov. And our staff can click on those links. They're live links in our system. So they could open it up and see what the site is. In Wisconsin, there's also that mobile app, which our staff, connects us as well. So they could walk somebody through it. Like, okay, do you see the button that says manage my case down here? That's what you're going to click on. So they can see what the member is looking at. We're just not, in some of these states, not able to do it for them like we can in Arizona. Oh, goodness.
Yeah. All right. Looks like we got some more questions.
Yep. So I see one here. Nope. I think I see one more. So how do I know which category A, B, or C my state is in? The states are supposed to be communicating that information out. In instances where they're not, Vicki has been certainly proactive in talking to the state Medicaid directors. So please just drop us a note. Kesley has her information right up there. If we know what's going on in your state, we're happy to sort of share with what information we've received. But in practice, in theory anyways, you should be getting those communications coming out from the state Medicaid administration. And unless another one pops up, that's all I see.
All right. Well, thank you everybody for your time. We would love to chat. My email, my phone number, whatever. I'm in sales, so I answer all calls, even if you're not already in my phone. So would love to hear from you.
Thank you.
Thank you, everybody.
I'd like to remind everyone that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks
Right.
again and stay safe.
Thanks,
Thanks,
Ron.
everybody.
Bye-bye.
Bye.
Bye, everyone.